Okay, our next topic is looking at hormonal regulation of bone growth. Of course, there's growth hormone, which stimulates the epiphyseal plate that causes interstitial growth and causes bones to get longer. Then you have thyroid hormone, which modulates the activity of growth hormone. Growth hormone actually works a lot better if thyroid hormone is also active. And then at puberty, testosterone and estrogen would actually promote adolescent growth spurts, but later they actually close the epiphyseal plate and turn it into an epiphyseal line, especially that of estrogen and its derivatives. Bone remodeling is also something that we want to look at. Bone remodeling is going to include both bone deposit by osteoblasts and bone resorption by osteoclasts. So this occurs at both surfaces, the periosteum and the endosteum. In healthy young adults, total bone mass remains constant because of an equal amount of bone deposit and resorption, but as you get older, one may outpace the other. Remodeling doesn't necessarily occur uniformly, but it is going to match how often you use certain bones. The regulation of bone remodeling is undertaken mainly by parathyroid hormone, which can be abbreviated PTH. There's also calcitonin, which can do the opposite of parathyroid hormone, because parathyroid hormone stimulates osteoclasts to resorb bone, thereby breaking up the matrix and releasing calcium, which raises blood calcium levels. Calcitonin, by doing the opposite, will lower blood calcium levels by suppressing osteoclast activity and increasing osteoblasts, or the amount of calcium secreted in the urine. Here we can just see a couple examples of bone growth and bone remodeling. So we can see that the bone has gotten taller, that's bone growth. Bone remodeling is where we've remodeled the diaphysis, so it used to be a little bit more internal, now it's a little thicker, that's appositional growth, and the epiphyses moved up, so we've had some smoothing out of that spongy bone that was previously there. But let's look back at those hormones like parathyroid hormone. Parathyroid hormone especially is going to focus in calcium homeostasis. And as you move throughout this course, you'll notice how important calcium is. It's important in things like releasing neurotransmitters, mitosis, and now we're talking about its importance in regulating osteoclast activity, but also in raising or lowering blood calcium levels. If you were to experience an imbalance, say a drop in blood calcium levels, that would be a stimulus which talks or communicates via the blood to parathyroid glands. Parathyroid glands are located on the back of the thyroid. You can have anywhere from 4 to 6. 4 is an average. The parathyroid glands, when stimulated, will release parathyroid hormone. So an upregulation or an increase in the amount of parathyroid hormone in your blood will actually activate osteoclasts. Osteoclasts resorb bone, so their resorption will degrade the bone matrix and release the calcium phosphates into the blood. Calcium being added to the blood will raise calcium levels, returning you back to a homeostatic balance, and that would be the effect that occurred because of the initial stimulus, which was a drop in blood calcium levels. Calcitonin would do the opposite of PTH, which is parathyroid hormone. So what we just looked at was rising blood calcium levels, and they would trigger calcitonin, which is the opposite of parathyroid hormone. And then PTH was triggered because of falling blood calcium levels, and that's what we saw in the last image. I also mentioned how important calcium is, and some of this you'll learn later, but here's just a quick list. It's important for muscle contraction, which will be chapter 9, transmission of nerve impulses, which will be chapter 11 through 14, blood coagulation, secretion by glands and nerve cells, which will be endocrine system, anatomy, physiology. We touched briefly on blood coagulation and cell division. Alright, now let's take a minute away from the physiology and just look at classification of bone fractures. These are breaks. So bone fractures are breaks in the bone. Now, bone fractures can be classified by a couple of different ways. There's first the either-or classifications. So either the bone break is non-displaced, meaning the ends retain their normal position, or they're displaced, meaning the ends are out of alignment. Also, bone breaks can be complete or incomplete. So incomplete means the bone isn't broken all the way through. Complete means the bone is broken all the way through. And you can combine these. You could have a complete non-displaced fracture. There's also other classifications of bone fractures. You can have a linear or a transverse or a compound or a simple. The linear fractures are parallel to the long axis of the bone. So think of them more of an up and down if you're looking at a long bone. Transverse is across or perpendicular to the long axis of the bone. So think of breaking a bone in half. A compound fracture is when the bone ends penetrate the skin, or is also called an open bone fracture. A closed or simple bone fracture is when bone ends do not penetrate the skin. There's still other ways we can describe fractures. We can talk about their external appearance, the nature of the break, the location. But the treatment for bone fractures is reduction, which includes realignment of the broken bone ends, and if needed, use of wire or pins. It's important to immobilize the fracture. Usually that's by cast or traction, and a simple fracture could take up to 8 weeks to heal. Here are some other ways to talk about fractures. If we're talking about what they look like, we could talk about a comminuted fracture. This is when a bone fragment is broken into 3 or more pieces. A compression fracture is a crushed bone. A spiral fracture is a transverse fracture that looks like a spiral. An epiphyseal fracture is a fracture along the epiphyseal line. This occurs in the elderly. It could occur because of dying cartilage cells due to osteoporosis. There's also depression fractures, which isn't a crush, but it's definitely a pressure inward, really typical or found in skull fractures. Green stick fractures are common in children because their bones have more osteoid than hydroxyapatite salts. And as far as fractures are concerned, we want to spend a little bit more time in one of our last topics looking at how they heal. These are the 4 steps. First a hematoma, then a fibrocartilaginous callus, then a bony callus forms, and then last but not least, there's bone remodeling. The first step includes creation of a blood tumor. That's what hematoma means. So basically the break occurs, blood vessels also break, blood is going to swell the surrounding tissues, and then white blood cells and other cells come to clear up the debris, and after the debris is handled, then the bone starts to heal. And just like bone begins as either a cartilage or fibrous matrix, it's going to start to heal itself using a cartilage or fibrous matrix. We're talking about a long bone, so it's going to use hyaline cartilage. So it'll start to build a soft callus, which is the fibrocartilaginous callus. Then the soft fibrocartilaginous callus, which is cartilage, will harden. That's the bony callus. And then bone remodeling cells, so osteoblasts and clasts, will work to remodel the bone to look exactly like it did before the break. So let's just go through those steps in words. Hematoma, blood tumor formed. This includes a clot. This is the painful or most painful portion. So very swollen, very painful, very inflamed during the hematoma stage. Fibrocartilaginous callus is going to be a soft callus. Osteoblasts are already forming spongy bone within a week, but the fibrocartilaginous callus forms first, so that cartilage, soft granulation tissue, will be first. Bony callus again begins almost within a week after the fibrocartilaginous callus, and you'd form new trabeculae first before you form hard or compact bone. It could take up to 2 months before you have a firm union between the 2 sides of the bone. Then after that, bone remodeling takes place to make sure that the final structure resembles the original. So any excess material is removed by osteoclasts, then osteoblasts lay down a new bone matrix, make sure you have a compact shaft around the diaphysis. So make sure you know the steps of bone remodeling. You should know what order they go in. So hematoma, fibrocartilaginous, then bony callus formation, followed by bone remodeling. And then our last topic is homeostatic imbalances related to skeletal tissue. So let's look at osteomalacia and rickets. Osteomalacia is soft bone in adults, rickets is soft bone in children. Both occur because of insufficient calcium or a vitamin D deficiency, and the main symptom is going to be pain when you put weight on the affected bones. Usually with those with osteomalacia or rickets, you're going to see more osteoid than calcium salts in the bone, and that's why the bones are demineralized and weak. They're very soft. Kind of think of them as bendy. So here's osteomalacic bone compared to normal bone. So on the right, you have normal bone up top, osteomalacic bone at the bottom. You can see there's a lot less spongy bone. There's bigger spaces between the spicules called trabeculae. And reasons that osteomalacic bone could develop are things like celiac disease or kidney or liver dysfunction, or even anti-epileptic use. Essentially, it's going to be things that impair calcium absorption in your small intestine. Rickets is osteomalacia in children, so very similar, same cause, same symptoms. Normally in children you see the bowed legs. You may even see something wrong with the pelvis or the skull or the rib cage, but bowed legs are generally a hallmark of both osteomalacia and rickets. Osteoporosis is a group of diseases like cancer is a group of diseases, and osteoporosis is not necessarily treatable. We can't prevent it. Osteoporosis is commonly going to be something that's associated with old age. It occurs often in postmenopausal women, and this is just generally because the bones are so fragile, they are not going to have the support of estrogen, which promotes osteoblast activity and the laying down of new bone. So again, osteoporosis, group of diseases. It affects spongy bone more than compact bone. Bones become really fragile. If you ever heard of someone sneezing or stepping off a curb and getting a fracture like a hip break or a femur break, that's probably because someone has osteoporosis. And estrogen is protective. So women generally don't get osteoporosis till they're postmenopausal. So here's osteoporotic bone compared to normal bone. You can see that osteoporotic bone is porous. That means it's brittle, and that's how we get an easy break in a large bone like the femur. And then you have Paget's disease. Paget's disease is characterized by both excessive bone formation and breakdown. Later on in the disease, it's characterized more by excessive bone formation, and the bone forms so quickly that it's not well built, and so the bone that's laid down quickly is really usually deformed and painful, and you have reduced mineralization, so it might be soft or bendy. Treatment includes drugs like didronate and Fosamax, even Actonel, and we're not exactly sure what causes Paget's disease. It does seem to run sometimes in families. And that's it for Chapter 6, so make sure to go back and review all parts.